Good evening. On behalf of Alpha Phi Alpha Fraternity Incorporated, the Mu Lambda chapter, I'd like to welcome you to Mastering a Resilience Mindset on Prostate Health. My name is Ted Darlington, and the purpose of this event is to empower men and their families to learn a little more about your prostate health. We're going to talk a little bit about early detection and how to prepare before a cancer diagnosis. The moderator of our event today will be Derek Butts. He is a 9-year prostate cancer survivor and the president of the Prostate Health Matters. So please allow me to welcome Derek Butts to the stage.
Good evening. I know a master martial arts instructor was asked to train 2 students, an 11-year-old and a 28-year-old, for a martial arts tournament that was coming up in about 6 months. Each student had no prior experience. The instructor was asked to teach them forms, stances, fights, positions, and various techniques. He taught them how to prepare mentally and physically for combat situation. The master instructor was only given 6 months. On the day of the tournament, the goal was to place in the top 3 of the division. The 11-year-old was up first. He fought the white belts in his age group, and he did well, to the point where he was actually excelled to the yellow belt group. He also beat all the yellow belts in that division, and he excelled to the green belt division, where he didn't quite place well, but he placed 3rd place. He was happy with his results. As for the 28-year-old, he was up next. He fought all the white belts in his age group. Then he fought all the yellow belts in his age group. Then he fought all the green belts in his age group. But more miraculous, he fought the blue belts in his age group. He didn't quite win that division, but he did place 2nd place. He was happy, amazed, and absolutely exhausted after this. So what does all this have to do with prostate cancer? Picture yourself as one of the white belt students. If you're a 40-year-old man, picture yourself as the 11-year-old. If you're a 28-year-old man, picture yourself as somebody over 60. Coming to this experience and not knowing anything and being diagnosed with prostate cancer is like a white belt learning martial arts. They don't really know what to expect. They don't know what to learn. They don't know what to look forward to. Your martial arts instructor, that should be a urologist. A urologist is giving you a 6-month period based on a diagnosis to help you figure out over a 4 to 6 month time frame what you should do, if you should have multiple biopsies, if you should have a second opinion, but most of all, it gives you time to figure out exactly what needs to take place. The reason why this stands out from a martial arts comparison is you look at learning these techniques, it's about learning resilience. The students just didn't learn forms and how to fight in combat. They learned mentally and physically how to deal with the challenges of a combative situation. Because when you look at it, cancer is about combat, or cancer is your opponent. And depending on the aggressiveness of your component, it will determine what kind of treatment you have. And like I said, it's not really sure what the best outcome will be, but you know what you're going to be faced with. The significance of placing in the top 3 of any martial arts tournament, that symbolizes you understand and you can prevail and be victorious when it comes to endure. From a prostate cancer point of view, that means you're a survivor. Now, the significance of the different levels of belts going up into the tournament. You may be diagnosed with cancer, you may be treated, but that cancer may come back through reoccurrence. Each level may be another aggressive form of the cancer coming back. And each time you need to be prepared for it, whatever that may be. When you look at this from a perspective of how your urologist can help you with this, again, it's helping you determine mentally and physically how you can beat cancer. But most of all, how you can be victorious. Again, my name is Derek Butts. I'm a 9-year prostate cancer survivor. I come from 3 generations of prostate cancer with 2 generations of survivors. I'm also the president and co-founder of Prostate Health Matters. Tonight, we're going to take you on a journey of what it's mean mastering a resilience mindset around prostate cancer. This is really looking at what it takes to master prostate cancer from before you're diagnosed, when you're diagnosed, and after you're diagnosed. We're going to share the mental aspect before, during, and after through the cancer diagnosis, but also we're going to share insights and options, things to think about to extend that journey for longevity, but also just not today, for generations to come. We're going to have a component we're going to talk about research and the importance of research and what that really means. Tonight, I'll be joined by two other panelists. One of them will be Dr. Richard Kennedy, who's a former MedStar medical physician and World Bank physician. He's also a prostate and colorectal cancer survivor, but he's also a medical advisor for Prostate Health Matters. We also have the Delta Research and Education Foundation presenter, Dr. Yvonne Collins, who's a chief medical officer of County Care in Cook County Hospital and hospital systems. Let's begin the journey. If you could bring up the slides, please. So what does it mean to master a resilience mindset? Part of it is looking at what does it mean to be resilient? Resilience versus resilient. Resilient is what happens after you've been resilient. Resilient is the effect after being resilient. And resilience is really looking at, it's a process, it's an ongoing process to understand your ability to bounce back from adversity, to really look at challenges you may be faced with, but how you can endure those challenges when they come into your fruition. It's also looking at the mindset of your prostate health. Now, from a resilience mindset of prostate health, it's looking at what intentional and strategic investments will you make mentally and physically to understand the possible challenges you may face as a man going through prostate health. And how can you plan that survivor's journey before the cancer diagnosis? This really understands what is prostate cancer and what does it really entail. If you look at the numbers from the American Cancer Society, prostate cancer in 2025 is estimated to hit about 313,000 cases, roughly about 35,000 deaths. That's a lot. And if you look at the changes from last year, it's roughly about a 5% increase. The incident rates between advanced prostate cancer stages also about 5%. So what does that mean when you're looking at men? It means if you're a man over 50, there's a 1 in 8 chance that you'll be diagnosed with prostate cancer in your lifetime. And that's an African-American man. There's also going to be higher risk that you'll be diagnosed with prostate cancer in your lifetime. What are some of the common hereditary things to look for? Well, if you have a hereditary prostate cancer, which means either your grandfather, your father, or uncle has had it, there's a 60% chance you'll be diagnosed with prostate cancer. If you have a family history of breast cancer, because of the similar BRCA gene, which Dr. Kennedy will talk about, there's going to be a 21% chance, higher risk of being developed as a prostate cancer person. When you look at all these different cases, those that have a hereditary familiarity with prostate cancer in the family usually have a 13% increase of reporting prostate cancer or getting prostate cancer. When you look at this, the genetics and the conformity around this, it's still something being researched today, but most of all that know that you have a high risk. And the risk associated with this is going to be due to your family history. It's going to be to, if you're African American, just because of your heritage, but also genetics and ancestry. Most of you'll find in most of this is usually the Caribbean and West African ancestry. The ancestry relationship, when you look at how prostate cancer rears itself. Again, as I mentioned earlier, African American individuals have a higher rate, roughly about 2 to 1 when you look at this across the board. And when you look at incidence rates across that between other races, the white race, Asian race, Indian, Hispanics, we're the highest. And looking at this also is really understanding what does that really mean? Well, when you're looking for help in other things in your neighborhood or your community or your state, how does that help? There have been instances where National Institutes of Health, the National Cancer Institute, they were funded to do cancer research. But the government nowadays has decided to cut some of this funding, which is going to impact some of that research that's going to be taking place. So we're going to have to look at other places to go for help. The impacts of this are going to affect the research coming across, research you'll be exposed to, and the possibilities of moving forward. But tonight we're going to talk about things that you can actually look at, other avenues that you can pursue to get the treatment that you're looking for, and research that you can get involved in to make that work. I want to share a little bit about my journey. It's a little bit different. My father is a 31-year prostate cancer survivor. He was diagnosed in 1994. With that diagnosis, it's one of the things with the old generation, they didn't really talk about it. I didn't find out until after his procedure that he had actually gone through prostate cancer. But he instilled in me to kind of figure out and understand what it means to be a survivor. As I was going through I started researching and understand what does it mean to be prostate health ready? What does it really mean to help prepare for prostate cancer? I looked at changing my diet in 2002. At that time, I realized about 2005, my uncle was diagnosed with prostate cancer. In 2008, I noticed there was an increase in my PSA. From there, I was monitoring it every single year. The increase in 2012 and again in 2015. In 2015, my numbers went from a 3.32 to a 4.32. And that was alarming because I was asymptomatic. I had no symptoms whatsoever. I thought I was living a healthy lifestyle. I thought I was pretty healthy. I was riding 100 miles a week on my bike. I was teaching 3 martial arts classes a week, and I had a pretty good lifestyle. But the active surveillance is something the doctor recommended even after I told him about my family history. This is something that didn't sit well with me. I figured as a Black man with a family history, the last thing I wanted to do was just sit and wait. So I sought a second opinion in November of 2015. The second opinion doctor, he looked at my results. I had a MRI to kind of figure out how the lesions had actually spread or where they were actually located within my prostate. At that particular point in time, he said, I'm really not the person that can do this, but he told me about a clinic that he went to at NIH that did cancer research. And he said, I've got somebody who can help you with this. I proceeded to be referred to NIH. I went and had what you call a fusion biopsy. That's where they overlaid my MRI with my prostate, and they did a biopsy of core samples, 12 core samples. I remember vividly that day on March 10th. It was actually 10 minutes to 5. I got the call from Mr. Butts. Sorry to tell you, but you have prostate cancer. There was a silence. After all, I've been preparing for this day for 15 years. And the lady came back on the phone. She said, we want you to come in for a consultation. I immediately said no. I said, I've been waiting for this day for 15 years. I want you to take it out. Can you do it next week? With a little chuckle on the phone, she said, we can't do it that fast. You'll be the next available. So this is where the preparation began. I prepared mentally as physically all along, but now I was in a pretty much a 6-week crunch to go from the March timeframe to the April timeframe for my removal. When they removed it, it was kind of a new lease on life. This is where I kind of began my journaling what my experience is like as a prostate cancer survivor. My father that morning, my procedure came in and said that he'd been working on a book. And he said, I'd like for you to finish it based on your experience. I agreed. And I started chronicalizing my journey from 2016 to 2019 and kind of helping to figure out what was going on, the highs and lows, the fact that my father had pre-robotics, I had robotic surgery, what that really meant. I also decided that for a point in time, I really wanted to help other men figure out what it was going to be like to navigate a prostate cancer survivor's journey. And I call it a survivor's journey because we want men to be able to catch it early. The reason why we're having this presentation tonight is for men that understand that prostate cancer is something that can be treated and it can be rectified, but if you catch it early. As the years progressed, I hit my 5-year mark. And I actually started an organization called, at that particular time, Prostate Cancer Awareness Alliance in 2020. We rebranded it last year to Prostate Health Matters. The reason being we had grown outside the DMV area, the DC, Maryland, Virginia, to other states like New York and New Jersey and South Carolina and Georgia. But I really wanted to help men understand what it means to navigate this journey. And I share this with you because everybody's journey is going to be different, but it gives you some semblance as far as what you may experience going through this. So who am I? Who are we? Again, as I mentioned, Derek Butts, 9-year survivor, also the president and co-founder of Prostate Health Matters. You're going to hear a little bit more from Richard Kennedy, who's going to talk a little bit about his journey, also as a prostate cancer survivor, but also as a colorectal cancer survivor. Prostate Health Matters was formed to create and foster awareness and proactivity in men. We really wanted men to be focused on what does it mean to be proactive with my health. Too many men over the years I've talked to, they get diagnosed, they don't know what to do. They're really trying to figure out how to navigate this journey. A lot of men, they hear the word cancer and they don't hear much else after that. So we really want men to be understanding and know that you can't do this alone. It is a journey. So we developed this space where men can actually talk and have candid conversations We do a lot of in-person as well as virtual events, and it's really to help men understand what they can do to survive. We share survivor stories, we share resources, we have education, and we're going to hear more tonight from the Delta Research and Education Foundation about the research aspect about this, because this is important. But most of all, with our organization, we want men to help them understand and get a grip on prostate cancer before it happens. Over the past 4.5 years, we worked with a number of different organizations across the board, varying from Zero Cancer to Hackensack Meridian Health to Georgetown, you name it, we pretty much have done it. And we're continuously being asked to expand into different cities. As a small nonprofit, that's a hard task to do. But they like the model that we have because we connect those prostate cancer treatment entities with underserved neighborhoods. We help connect those entities that may not be familiar with those prostate cancer treatment services that exist within their neighborhood. And this is important because a lot of times men don't understand where to go first. They may live within 5 to 10 miles from a hospital. They don't really understand what they offer in the way of treatment when it comes to prostate cancer services. Over the years, we've actually reached over 3,800 men. Additionally, we've helped perform 391 prostate cancer screenings, which was a simple blood test. Again, we've done programs in different states. We're being asked to expand to places like Houston, Chicago, California. All these places have the same requirement of helping them understand. We've also been instrumental in working with the boards, community outreach and advisory boards and advisory councils for Georgetown University Medical Hospital, University of Maryland Greenbaum Cancer Center, and Hackensack Meridian Health. These are just a few that we're actually working with across the board, and we're being asked to do more. As I mentioned earlier, my father and I wrote a book. The book is labeled Prostate Cancer Family Affair. And the reason for the book is when we initially did our research, there are a lot of books out there on prostate cancer. There were very few written by Black men, and there were very few that written that weren't doctors. Most of the books are written by doctors, were usually about 200 to 400 pages long, with a lot of medical jargon. And that was a little cumbersome for somebody to kind of navigate. The book that we offer is just a quick book on navigating prostate health. It really talks about the highs and lows that we went through. But most of all, it's just in plain speak, just as you and I are having a conversation. We want men to understand, without the medical jargon, what it really means to be proactive, questions to ask your doctor when you go to the doctor, but most of all to know that there is a quality of life if you catch it early. And most of all, your family wants you to be around. At this particular point, I'm going to turn this over to Dr. Kennedy, and I want him to share some of the factors that we have here. He's going to share his journey in addition to some of the risk factors and other things related to prostate cancer. Dr. Kennedy? I think you're on mute.
Thank you very much, Mr. Butts. I'm very glad to be here. Before I start with going through these slides, I want to tell you just a quick bit about my story. My dad was diagnosed with prostate cancer in 1988. And at that time, I'd been a physician about 4 years. And, I went with him to the urologist. And back then, the treatment of choice for prostate cancer was removal of the testicles, because the belief was that the testicles had testosterone, which they thought was a stimulus for promoting prostate cancer cells. And of course, my Jamaican dad didn't take too kindly to that. And in very stern words, he told the urologist, he said, "I'll have mine removed after you take yours out." And so he basically, and I tried to, the doctor looked at me and said, "Well, you're a doctor, talk to him." I said, "He's the patient. You need to convince him that this is the treatment of choice." But my first thought was, there are other options out there. And we don't have enough information. All you had was a PSA. And the PSA, again, was elevated. And as Derek said, his PSA ended up being 4.3 something. The normal PSA is 4 or less. My father's was 103.2. And so that meant, at least to me, that he already had prostate cancer that had left the prostate and had gone to other areas. And that was true. It ended up in his spine and in his lung. So this other options of radiation was there, and chemotherapy back in 1988 wasn't very good for prostate cancer. So they said, well, we'll give him hormone therapy. And of course, the side effect of the hormone therapy, because it was to counter the effects of testosterone, it basically was an estrogen type drug. And basically it, yes, it shrunk the testicles, but it also gave you breasts, which of course to my dad was unacceptable as well. So he opted in 1988 to do nothing. And other than the back pain that he constantly had, he lived for 12 years with the prostate cancer before he finally succumbed. But during that time, I realized there's a good chance this is going to happen to me. And of course, I was monitoring my PSA. My PSA never got higher than 4.1. And when it did get higher than 4.1, it went to 4.8. And I was comfortable with it. But my wife said, no, you got to go and get another test and see someone else, because the urologist was fine as well. I went and had a second opinion. They basically said, let's do a biopsy. And again, I had no symptoms. There were no urinary symptoms. There was no blood in the urine. I wasn't having bladder or bowel problems, which are all typical side effects that can happen with more advanced disease. And I didn't have any of that. But when they did the biopsies, I had 16 biopsies throughout my prostate. 13 of them came back with cancer. Because it was still confined, they said that I could opt for surgery or radiation. I went through several opinions. I went to radiation oncologist, the person who does radiation for cancer treatments. I went to 2 different urologists and a medical oncologist. And basically, I settled on surgery. And because it was localized, I had what we call a radical prostatectomy, which is removing the prostate entirely, sparing the nerves, and taking out the lymph glands and the blood supply in that area. And thank the Lord, I've been fine with no detectable PSA since 2011. Now, as it relates to the different tests that are available today, so we've come a long way. The PSA used to be the standard, but it's important to note that with family history, and as Derek said appropriately, it's really important to know what your family history is. You can, and because we live in a time where the older generation is not really good about passing on information, you have to really reach out and ask, because it's important. And since that time now, my younger brother, who's 56, has been diagnosed with prostate cancer. So we know that it runs in families. And now there are these different tests that are available. Next slide, please. And the tests are selective for each individual based on family history, whether your age, what are the comorbidities. And as was said earlier, when you have a family history of breast cancer or colon cancer or any other kind of cancer, the risk goes up. Derek showed a slide earlier that basically said 1 in 8 men during their lifetime will get prostate cancer in the United States. Well, for African American men, or those from the Afro-Caribbean area and from West Africa, it's 1 in 6, sometimes 1 in 4, depending on the parts of the country you're in. So it's really important. The PSA is a simple blood test. The 4K protein test is another blood test that actually breaks the PSA or prostate specific antigen down even a little bit more. And it, with other studies, they may do a CT scan, a PSMA, which is essentially what we call a PET scan, specific for the prostate. It picks up cancer cells. MRIs, again, because nowadays when they get ready to do biopsies, they want to target where the cancer is most likely, and the MRI allows you, i.e. what Mr. Butts had, the fusion biopsy, which will tell you where to go so you'll get greater yield. And there are different ways. If it's very localized and they use a score called the Gleason score, less than 7 is a low-grade tumor, most likely, if it is prostate cancer. And those people might be recommended to do active surveillance, which is you watch it, which means every year you're going to at least have a PSA blood test. People don't do the digital rectal exams as much anymore. And in the past, for a lot of men, that was one of the main reasons why they didn't tell people that they were even having symptoms back there, because always thought of it as an invasive procedure. At other times, it's indicated, and it's important that we do that. The treatment options for prostate cancer, again, active surveillance, which is watchful waiting. Surgery with radical prostatectomy, which can be done robotically or without robots. The hormone therapy has become more advanced, and you tend to do this more often with people who have more advanced stages of prostate cancer, meaning Gleason scores of greater than 7, but less than 10. And same thing for radiation, and there are different types of radiation. There's radiation that targets just the cancer cells in the prostate, and that now is what we call proton therapy or photon therapy. And its advantage is that it only kills the cancer cells in the prostate, but does not damage the surrounding normal tissue. CyberKnife has similar results, but not as good as the proton therapy. The radiation brachytherapy, the problem with that is that it will get rid of the cancer. And think of radiation as something that's literally burning the tissue to kill it. And unfortunately, surrounding normal tissue will become part of it. Next slide, please. So, and again, as Mr. Butts said earlier, it's much more likely that in African American men, particularly those with a family history. And so now my son, because now his father, grandfather, and uncle have had it, he's at risk during his lifetime. So I've even recommended, and so has his primary, that he starts screening at 40, just because there's such a greater likelihood. And because most prostate cancer that becomes symptomatic is almost always what we call metastatic, meaning it's already spread beyond. And so it's harder, not to say that you can't treat it today, because there are many options, but it makes it more difficult. Next slide, please. So where can you get a PSA test? So as the slide says, there are 8 states and the District of Columbia that give you free PSA tests. The labs, the 2 largest labs in the country, LabCorp and Quest, do them. They're approximately $72 to $80 per test. But many local churches have health fairs, things like that. I would always say start with your primary care doctor to find out what's available, or go online to the local hospitals where you live, because they will always be announcing when these free tests are being done. And it is just a blood test. And so it's something that really will help. And when they have most places will have an annual health fair like they used to do in DC all the time. And they'll have plenty of places like that as well. Next slide, please. Next slide, please.
With a question in the chat, Dr. Kennedy, if you could answer this before we move forward. So one of the questions that came up, if you have a family history, can MRI is a good preventative measure, and is it a reasonable solution when it comes to detecting prostate cancer?
It's a reasonable start with a family history. I would actually recommend that a person who has a family history, particularly first-degree relative, that they also get genetic testing, because we know that with the BRCA1, BRCA2 genes, that if it's positive in those people, their risk for aggressive prostate cancer down the line goes up. And so it's much more important to get those tests early on. The 4K test helps to determine whether that is going to be the next necessary step. And most of the urologists are doing it. Many primary cares won't do it. And a lot of this is based on the PSA. And I think it's really important to take away from this that a normal PSA, which is less than 4.0, does not necessarily indicate that you do not have prostate cancer. It's why they do the PSA serially, because a person can have a normal PSA of 2, for instance, this year, and next year it's 3.1. And typically most people believe that if it's more than a 50% change from one year to the next, that's concerning. And that then leads to more detailed investigation.
Another question in the chat was, can a change in diet can change the potential outcome of being diagnosed?
I think the answer is yes and no. And that one has to consider. I'll use myself as the example. When I found out I had prostate cancer, and I had 13 out of 16 biopsies that were positive for prostate cancer, but all of them tended to be on the left side of my prostate, and I had no symptoms. And I was reading a book about eating green vegetables, fruits, and things like that. Mm-hmm. And since it took 3 months for them to schedule the surgery, I said, you know what, I'm going to do smoothies twice a day for that and see what happens. And when I actually had the prostate removed, the urologist was somewhat surprised, because since he's the one that did the biopsies, he expected to see that similar amount. when he got in there, half of the cancer that was in my top part of my prostate was no longer there. So in that point, I would say, yes, it does make a difference. But it also is important to get regular exercise. It's also important to have a good mental aspect of it. You have to look at this. And I tell people, and again, being a dual cancer survivor, you are that for the rest of your life, because we know that prostate cancer can return. And the treatments in which it tends to return more frequently than not tends to be the radiation.
Okay.
And so, and that's why you have to pay attention to that, and make sure. And I always say that one of the things that I found in my career is that patients can be in the room with you. You have a discussion with them. You tell them what's going on. You ask them, do they have any questions? And I always say, the moment the word cancer is put out there, people shut down.
Yep.
Because the first time I heard the words cancer 21 years ago for me, I shut down and I didn't hear a word after. And I was in there another half an hour with the doctor. And thankfully, my mom and my wife were there, because I didn't hear a word. And I'm a doctor. Yep. I do this all the time. I did this all the time. And I know how I shut down. So I know that I know my patients do. And it's why and patients typically, the majority of them don't ask a lot of questions.
Yeah.
So you have to push them.
That's good stuff. At this particular point, we're going to kind of go through, we want people to understand, as we're talking about this in the stories, and like I said, it's important that we share these stories because we want to tell the different courses, the different lifestyles, the different expectancies that people go through. Everybody's not going to have the same results. But what we're trying to stress here is we want to make sure, as we stressed enough, your PSA is kind of the number one go-to to figure out what's really taking place. We want to understand what your PSA is. We want to understand your family history. As I mentioned with my father, with Dr. Kennedy's father, each of us come from a family history of prostate cancer. To my point, where my family, my father, my uncle, my grandfather had it. When I was diagnosed, it was one of those things I had to get my sons to better understand. They had to be proactive with their lives, but even more so, my brothers within the past 2 years have both been diagnosed with prostate cancer. So 4 men within one family. That's how it actually spread within our family. And one of those things, it wasn't as a matter if we were going to get it, it was just a matter of when we were going to get it. So we were all prepared for it. And luckily, we've all been able to be victorious and stepping away from it. But I also want people to know, as I mentioned earlier, you got to ask the doctor questions. When the doctor asks you what's going on and how are you feeling, don't tell them you're fine when everything is not. Tell them if you're getting up and going to the bathroom in the middle of the night. Tell them if you're having problems urinating. Tell them if you have pain or aches in your groin. These are things they need to know because they can't determine what's going on with you if you're not truthful with them. And most of all, the other thing was number 4, if you are given treatment options and you don't like it, it's okay to ask for a second opinion. Nobody's going to fault you for asking for a second opinion. The doctors are not God. They're just conveying information based on what they know, what they have available at their disposal. We also want you to know your family wants you around. So get that cure, find out what's going on with your prostate and figure out what's going on. And as we mentioned earlier, prostate cancer can be 100% curable if you catch it early. But most of all, we want people to know there is a quality of life after prostate cancer. And what I want to do is now I want to turn the floor over to Dr. Yvonne Collins. And Dr. Collins she's a medical gynecological oncologist, currently the chief medical officer at County Care with Cook County Health Hospital Systems. She's a board certified obstetrician, gynecologist and gynecologist oncologist, and she's also representative of the Delta Research Education Foundation. And with that, Dr. Collins, I'd like to turn the floor over to you.
Good evening. I have the slides up. Thank you so much to Prostate Health Matters and the Mu Lambda chapter of Alpha Phi Alpha. I love the conversation. I'm a GYN oncologist. I take care of women's cancers, but some of the points that I want to make sure that you all take away tonight is the conversation. The Black community very commonly keeps things secretive within our families, within our
Mhm.
communities, and so often people suffer in silence when they don't have to. So thank you very much to Mr. Butson, Dr. Kennedy, for telling your story. Everybody needs to tell their story because someone can learn from that story. So my name is Yvonne Collins. I am the Chicago Citywide Coordinator for the Delta Research and Educational Foundation. Research matters for all of us. Next slide. As we talk about research tonight, I really want to highlight for you the importance of it and the campaign that we're doing to ensure that all of us are a part of the research. If you can play the video for me.
The National Health Initiative, conducted by the Delta Research and Educational Foundation in collaboration with Delta Sigma Theta Sorority Incorporated and the National Council of Negro Women, is entitled Research Matters, Creating Possibilities to Achieve Health and Wellness for All of Us. The objectives are to engage, educate, and ultimately enroll African Americans in the National Institutes of Health All of Us 1 in a Million campaign, a national database primarily comprised of diverse and traditionally underrepresented populations. The mission of the All of Us research program is simple. It is to speed up health research and medical breakthroughs by asking 1 million people to lead the way to provide the types of information that can help create individualized prevention, treatment, and care for all of us. The All of Us research program is a part of the Precision Medicine Initiative created during President Obama's administration. Precision medicine is healthcare that is based on you as an individual. It takes into account factors like where you live, what you do, and your family health history. Precision medicine's goal is to be able to tell people the best ways to stay healthy. If someone does get sick, precision medicine may help healthcare teams find the treatment that will work best. This will help give healthcare providers the information they need to make tailored recommendations relevant to people of different backgrounds, ages, or geographic regions. African Americans continue to have some of the highest incidence, prevalence, and mortality rates from chronic diseases such as cardiovascular disease, diabetes, obesity, hypertension, mental health, and HIV/AIDS. Yet we comprise only 5% of clinical trials participants in America. Our focus and objective is to create awareness about how research matters in closing the health disparities gap. For more information, please visit www.joinallofus.org/DREF.
Thank you so much. You can go back to the slides. So, really, the goal of this campaign, and I won't call it a clinical trial, I'll call it the campaign, and you can go 2 slides actually, is really to take communities, help them understand their healthcare risk, and learn the importance of what precision medicine is. So, if you think about precision medicine, we don't want to give the same drug to everybody because we know that we'll get the same result very often. When we talk about cancer, now we have genetic abnormalities that we can target so that we can treat everybody based on that genetic abnormality. That's what the goal of this particular research program is. Next slide. What we also know is that over the last 10 years, this graphic shows where we are in terms of this All of Us research program. It started as a pilot. During that pilot of 5,000 participants, a lot of information was garnered and gained. It then became a full-fledged program in 2017. And over that period of time, we're going to look at some data. But not only have we accrued participants from very diverse populations. We've also focused on how we begin to educate the community. We focused on how we build scientists. We focused on how we help researchers. What we hear very commonly is, why aren't there more folks of color in clinical trials. And scientists very commonly say, because I don't have that kind of patient in my clinic. And so we don't want that ever to be the reason why folks like us are not studied. And so we want to equip scientists to be able to do the appropriate research. Next slide. When we look at the All of Us campaign, it's based on you as an individual. As the video showed you, it takes into account what makes you different as an individual. So although Mr. Butts and Dr. Kennedy both had prostate cancer, if we were to do genetic testing on those prostate samples, each of those would be different because they live in different areas, they have different family history, they probably have different lifestyles and different environments. And we know that it's important for us to study a multitude of folks in order for us to really get a good sampling of what's going on in the community. And the reason why we do this is because when we look at medicine, especially cancer, we know that there are disparities in terms of populations. We'll look at it a little bit later, but you've heard it over and over and over today. We know that Black men are disproportionately impacted by multiple diseases, but we'll focus on prostate cancer today. We know that they are more likely not to be diagnosed early, which improves their cure rate. We know that they're more likely to have advanced disease and die from their disease. So, why is that? Our hope is that with precision medicine, just like we've seen increased genetic markers identified, we're hoping that we can move the needle also on prostate cancer as we've moved on so many other disease as we look at it, the genetic profile of many members of the community. Next slide. So we know a healthcare disparity is really a higher burden of whether it's injury, whether it's illness, whether it's disability or death on one particular group over another. And so when we look at that, we want to be able to identify those differences, target them, but also make recommendations based on those differences that we know potentially have a better impact. Next slide. And so that's exactly what we're doing. With cancer, we know many healthcare disparities exist. With cancer, we know that African Americans have higher mortality rates. They're more likely, just about with any cancer, to be diagnosed at more advanced stages. They have less access to clinical trials. Maternal health, we know that African American women are 3, sometimes 4 times more likely to die either prenatally before they deliver, during delivery, or post birth. And we also know with heart disease, African Americans are 30% more likely to die from heart disease than when we look at non Hispanic whites. Why is that? And so our goal is really multifold. It's a promise to our participants. We want them to be able to improve their health, to learn about their own diseases, to have access to their own data to ensure that they are in the community and understanding the effect on their health. We want them to have an opportunity to learn about what research does and what research is. And we want them to meet other people so that they understand that everybody can be a survivor if they participate. And we also want to show the long term relationship and the value of research, which I'm going to talk about in just a moment. Next slide. We also want folks to understand that when we look at research, the goal is that we want to make sure we have participants. But what we hear very commonly about why folks don't participate in clinical trials is my data protected? Who else can see my data? What happens with my data? So the data is protected. Very commonly in the African American community, we hear about Tuskegee so often. We hear about George Sims. We hear about Henrietta Lacks and all of those things that happened. I don't want to dispel those and downgrade them because they happened and it was unfortunate. But I want our community to understand that if we are not a part of the research, we'll never obtain and be able to benefit from the impact of clinical research. The things that you heard tonight are exactly from clinical research. How did we move from an open prostatectomy to a minimally invasive robotic prostatectomy? It was through research. We know that there are no differences in expectancy in terms of outcomes related to life. How did we move from surveillance to being able to give hormonal therapy or chemotherapy, it was really because of research. And so research is really important to our community. Next slide. When we look at it, the current protocol now for this particular campaign is um, you consent, you can connect your electronic medical record and we can pull data from it. You answer surveys related to your medical history, your medications, your environment, your lifestyle. All of your measurements are taken, your blood pressure, your height, your weight. We also get biosamples, that is blood and urine. If you wear your handy dandy little Apple watches or Fitbits, we can connect that information into the system. And why is all of that important? Because sometimes you don't remember or you don't know the impact that something in your life has had on the disease that you have now. What we're seeing now, someone asked a question related to diet. We know that for those who have sugary foods, who have processed foods, who have lots of red meat, do significantly worse related to therapy, especially chemotherapy and radiation for most cancers, but also prostate cancer. How did we learn that? Because we compare different communities. The other part of this protocol, which is really important, and that's why it's called All of Us, because we know that each of us is different. We want to make sure that if we are using a device or a medication or a surgery on the Black population, we want to see that same study done in the white population to make sure there are no differences in terms of response rates and effectiveness. That's why it's all of us. We understand that we have to study all of our populations in order to see differences, and that's why it's so important. Next slide. The goal really was to have 1 million participants. This is just a snippet as of this month where we are related to enrollment. You can see we have about 860,000 participants. Almost 600,000 of those have actually completed all of their surveys, all of their blood work. But what's important here, I don't know if you remember from the video, but about 5 to 10% of most clinical trials are underrepresented minorities. We can see here we have had almost 80% of underrepresented minorities, and that's really the job for the Delta Research and Educational Foundation. We want to go into the community, we want to educate the community, we want to partner with the community, and we know with those two pieces, folks are more likely to become a part of a clinical trial because of the trust and the relationship that's built. When we look at researchers, we also know when we look at researchers, we're now seeing more underrepresented minority researchers. And why is that important? When you look at all of the data, if I, as a Black woman, walk into an office and I'm going to be treated by a white physician compared to a Black physician, I'm going to have a very different outcome. And so, because we know that, we want to ensure that researchers are looking like the folks that they're taking care of because we know that makes a difference in impact. The next slide. When we look at it, we have seen from a hereditary perspective, we have identified new genetic markers and tests that I'm going to talk about in just a moment. But we've also seen, based on those DNA samples that we have obtained from the study, is we're now able to see which medications work better in other populations. You'd be surprised if you're taking medications now that the vast majority of those medications have never been studied on anybody that looks like you. And so now we're beginning to see medications that high blood pressure. Why is Mrs. Jones' blood pressure not going down? Because Mrs. Jones is on the wrong medication, and that medication will never work in a Black woman. And so that's really the benefit of what we're starting to see and what we hope to expand with the All of Us campaign. Next slide is a graphic really of where we are. You can't see it, but I wanted to give you a little snip. So about 860 participants. If you look at the top left, that's the age group. We have just about every age group. We just started in the pediatric population. But if you look at 18 to 80, we cover all of the age groups. If you go to the top right, when we look at ethnic groups, we have all of the ethnic groups represented. You can see that Blacks and Hispanics Hispanics, again, often single digits or double digits in these numbers. And so when we look at sexual orientation, not included on this slide, we are getting those that have different sexual orientations because, again, we want everybody accounted for and studied so that we can really learn the impact of the research that we're doing. Next slide. As we focus on prostate cancer, you've heard it today. Black men are 70% more likely to develop prostate cancer than their white counterparts. They're twice as likely to die from prostate cancer. You've heard some of the genetics today with a focus on BRCA, which is the same gene that is the culprit behind a lot of breast cancers and ovarian cancers. But there are so many other genes. There are Lynch genes, which are associated with colorectal cancer genes. There's TP53, which allows you to see the aggression of tumors. And so, really, that's where genetics becomes really important because, and that's why when we look at prostate cancer, we want to make sure that especially when we see it in a family, someone that has been affected, we want to test them first because they're more likely to have the genetic abnormality. And we don't want to just test for just BRCA1 or 2. We want to do a complete genetic profile so we're able to see, are there any actionable genes that we can actually target? And that's a little bit of what we're starting to see. Next slide. When we start to look at the research, you heard it early, risk factors of age, the older you are, the more likely you are to get prostate cancer for men, breast cancer for women. We talked about race. African American men are much more susceptible to prostate cancer. When we looked at heredity, that is heredity in terms of genetic abnormalities that I mentioned earlier. Family history, we can't take it for granted. So when you look at a gentleman that has prostate cancer, if his first degree relative, that is a brother or father, had prostate cancer, he's twice as likely to get prostate cancer. If you have three first degree relatives, and I think Mr. Budd said it, so you have three brothers and your father, you're four times more likely to get it. This is why it's so important when you're seeing your providers that you talk about your family history. And that's really important as a community that we understand the risk that's in our families because we can't solve for it if we don't know it. Next slide. The next slide really highlights what we're learning. This is just one of the many studies that we're learning based on this database. So does environment matter? There was a study that was based at the University of Illinois, Chicago, which really looked at high-risk cases and found that there was a positive association between the environment, your environmental quality, and the likelihood of developing metastatic, that is prostate cancer, that's left the prostate and gone to other parts of the body. So it is the air you breathe, it is the water that you drink, it is all of the toxins that are potentially in your soil. So those things that we eat. So when we think about it, some of it I always say is strategically designed for us not to survive and thrive. Because when we look at Black communities are more likely where? Near refineries, they're more likely near railroad tracks, they're more likely near highways, and all of those pollutants play an impact. We see it now related to prostate cancer, but we're also seeing it for maternal morbidity and mortality. So, yes, the environment matters, and that's something that we can change and do something about. The next slide highlights really some other things that we're seeing in the All of Us campaign. So we found, not surprising, but it's always good to actually see it in the data. Black men are 17% less likely to get a PSA screening. So I had a scenario, a friend of mine called me. Her grandfather was diagnosed with prostate cancer. He saw his primary care doctor every 6 months for the last 20 years and had never had a PSA until he had symptoms. That is medical malpractice. For someone who not only is a Black man, but had a risk factor for prostate cancer not to have a PSA. We're learning that DNA testing can be used to determine how well chemotherapy works. So, wouldn't it be great if we could do a risk score, know if you're low risk, medium, or high risk. Use that risk to then determine which therapy you may or may not respond to. Just imagine the number of folks that we would not unnecessarily treat, the number of folks that we could potentially be given the right targeted therapy to make a difference. Not only the toxicity that comes with radiation, chemotherapy, or hormonal therapy, but also the financial toxicity that we very commonly don't talk about related to these cancers. So I really wanted to give you just a snapshot of what we're doing. Next slide. And we're really asking all of you, if you have not, to really join us in as we move all of us forward. You can take out your device. You can go to joinallofus.org/DREF. It's also in the chat, and take the first step in creating that account today. The next slide, you can follow us on all of our social media platforms. So you can see we're on Facebook, we're on Instagram. You can research you can email our office, but we would love for all of you to join us. As I close, I want to just add one other thing that we talked about earlier. I want you all to understand really that not only environment makes a difference, but diet makes a difference. And really, when we look at prostate cancer, we have the opportunity, just as we see in breast cancer and ovarian cancer, to hopefully make a difference. And early detection matters, screening matters, paying attention to symptoms matters. And so I encourage each of you to do that, whether it's prostate cancer or any of the other cancers that we screen for. Become a part of the solution. And again, thank you so much.
Thank you, Dr. Collins. That was an amazing overview. And as Dr. Collins stressed, we want you to be proactive when it comes to your prostate health. We don't want you to wait for symptoms. And part of the research and the understanding and the studies that she talked about is not just helping the current generations, but the future generations to come. The advancements in technologies and innovations that are out there, we want to make sure people understand it does take us involved. And I saw in the chat, somebody mentioned earlier, the participations at one of the pharmaceutical companies, 84% was more white Americans. When it came to African American participation, it was about a 6.7%. And across the board, when you look at some of the national research, clinical trials, and studies that have taken place, only about 4 to 6% of us actually participate in those, which means they're not getting the most and the best information to make the best decisions when it comes to treating the African American community. So at this particular point in time, I want to start moving to the questions and answers. I do want to go back to my slide deck real quick and just kind of re-indicate one thing before we get to that point. If you can bring up the slides. So again, mastering resilience is knowing your numbers. As Dr. Collins projected, your PSA, your family history, these are two key elements in beginning to understand what it means to be resilient. The family history can go way back. In lifetimes, we talk about the older generation. They don't really talk about the cancers. They don't talk about the ailments of the older generation, what have killed them. You need to ask them, what did they die from? What are the causes? This is going to help you better prepare for the things that you may face moving in your particular life, and also the future for your kids. Again, the treatments, the family, the long-term care, like I said, it's 100% curable if you catch it early. And also to make sure, I want to go back to the asymptomatic, because there were a couple of questions in the chat. A lot of times you're not going to have symptoms. I was asymptomatic. Dr. Kenny was asymptomatic. But the other thing is a diagnosis. So when I was diagnosed through the biopsy, I was diagnosed at stage 2B. 2B means the cancer was still contained within the prostate. However, when they took it out and they did a pathology report, I was actually stage 3B, which means the cancer has started to exude the prostate, but it was caught in the seminal vesicle. And this is important because even though we have great and innovative technologies, it's not going to catch everything. So you still have to be proactive in the treatments, the therapies, your diet, all those things you're going to go through. It's very important to be on top of it. And I also want to go back to, we talk about resilience in combat. It's preparing to win before the fight. As I mentioned earlier, the two analogies of the students, the two white belts, one was 11 years old and one was 28 years old. Their trophies or their win, there was their accolades for being prepared, going into the fight, understanding that they were going to escalate or be escalated and be able to prepare at each escalation. When we talk about prostate cancer and having the initial cancer treatment coming back, resilience is planning to live your life before and after the cancer treatment. even if it comes back, knowing that you can make it through if you prepared properly. These are important things we want to make sure people walk away with. There's a lot of information that we could share, but we only had 75 to 90 minutes. But we wanted to share enough information that people can go out, ask intelligent questions of your doctor, your physician, go to seek information if they don't give you what you're looking for, but better understand that you have to be the one driving that resilience. You have to be the one to figure out and helping with your helping urologist, your doctor. What are the things I need to do as an individual prepare for this fight? Because it is a fight. Remember, your opponent is cancer, and cancer is not going to fight fair. Sometimes it's going to move slow. Sometimes it's going to move fast. Whatever the pace may be, you need to be prepared. And with that, the questions I leave you all, and please put questions in the chat. We're going to start going through the chat questions to answer those. What will you do differently to begin to master your resilient mindset with your prostate health today? We thank you for that. And we're going to start taking questions in the chat. So I'm going to go back. Mikhail, if you can start posting those that we missed earlier on as Dr. Collins was talking about those, we'll start taking those systematically. As he's looking through that, how do you cope with radiation cyst? Dr. Kennedy.
Again, a lot of this is understanding what the treatment is, and the radiation oncologist should have in some way prepared you that this is a possibility, because it doesn't happen to everyone. There are different medications, because essentially a cystitis is an inflammation of the urinary bladder. And so therefore the person's either going to start having more frequent urinations or more painful urinations or bloody urine, etc. And so part of it is meeting with your urologist, your primary care doctor, and they'll come up with a treatment plan, because there are definitely different treatments out there that are beneficial and work. But the first thing is not to acknowledge them and not to comment that they're there. As they say, I was always told there's no such thing as a stupid question. The dumb question is the one you don't ask,
Right.
Because that's the one that doesn't get answered, and it may lead to other things. Sometimes it's a simple solution. Other times it's a more complex, but you have to be willing to ask them. I used to always tell my patients, you are guiding this encounter and this arrangement. I'm just there to help guide you down the direction you need to go. When I say halt, there'll be reasons why I give you why we should go in a different direction. Or I say, good job, we're going in the right direction. But you're the one, because you're with you 99% of the time. So you're the one who has to be guiding the relationship with you and your provider.
Great thing. Another question came. So one of the things also I mentioned, Dr. Kennedy, when we talked about these procedures, a lot of times the doctors will tell you the side effects of these procedures when they come out. And sometimes they may not always share all the side effects, which means you need to ask. Because every single procedure that we've kind of did a high level overview tonight will have some sort of side effect. The question is how severe and how will your body react to it? Another question in the chat comes up. For high risk patients that are still cancer free, what are your thoughts on removing the prostate before it becomes cancerous? This goes back to Angelina Jolie, where she proactively had a double mastectomy to remove her breast because of the genealogy and the fact that breast cancer was so high in her particular family gene. Dr. Kennedy, your thoughts on that?
It's not an unreasonable thing. The prostate gland has essentially only one function. It provides seminal fluid for sperm. And we know that men can still reproduce without a prostate. So not having it is not necessarily going to interfere with your ability if procreation is in your wheelhouse. That being said, you have to take into account the potential side effects from having your prostate removed. And for the two common ones are loss of control of your bladder function for a period of time, and erectile dysfunction, which in the world today is the one people tend to focus more on. And again, I was told by my urologist that I'd have erectile dysfunction for about 6 months. And they prepped me in advance by giving me the drugs like Viagra, Cialis, to prepare me so that when that did happen, my recovery would be less. But it took me 9 months, 13 days, and 1 hour before my bladder function was controlled. And so that was my most regulating concern. I would tell people, if you're going to have any kind of surgery or even radiation, I tell you, the first thing I tell every man to do is you need to start doing Kegel exercises every day. Because I think it makes a difference, because you need to strengthen that floor wall there to help you down the road.
Absolutely.
And women should do their Kegels too.
Without question. Without question.
Absolutely. That was one of the things that the doctors told me. But like I said, I was preparing for this for 15 years. So when it came time to crunch time, that 6-week period between the time I was actually diagnosed to the actual surgery, for me, being a cyclist, the day before my surgery, I did a 35-mile speed ride because I knew they were going into my core through the Da Vinci robotic system. And by doing that, I was strengthening my core to kind of break it down. I also did 350 body crunches the morning of my surgery because I knew they were going into my core as well. But what it allowed me to do is they wanted me to walk 1 mile around the recovery floor before I could leave. So that night, actually 4 hours after my surgery, I did 3/4 of a mile. They told me to slow down. They said, "Mr. Butts, we can see you're ready to leave." I said, "Yes, I'm ready to get out of here." But those are the kind of things that help prepare you, because it does shorten that recovery time. The Kegel exercises, what you eat, exercise you do, having a healthy body, and lifestyle beforehand all make a big difference. Another question in the chat: can you talk about what typical symptoms of prostate cancer look like and how the symptoms manifest themselves? For the men that we mentor, so we do mentor several men throughout the week, they're going through things like frequent urination. They may have pain when they urinate. They may have trouble emptying their bladder completely. And those are all different symptoms of different things. The other things may be they may see blood in their urine. These are other symptoms that can actually point to different things that may take in place. And some of these things realize they may be slow growing and some may be rapid when they actually progress. So if looking at that, Dr. Kennedy, I don't know if I missed anything, but for anything else you want to add, particularly on that, or Dr. Collins?
Well, occasionally you can have blood in your semen as well, with it. And the urinary, and I always say that the question that the person always asks about their urinary symptoms is, before they quote unquote are diagnosed with prostate cancer, were they having urinary? Because there are other things, because diabetes can cause some of this. Kidney problems can cause some of this. Urinary tract infection. There are a lot of things that enlargement of the prostate can mimic this. So this goes back to making sure you have a good question and answer session with your provider, and they're able to answer your concerns, because sometimes has nothing to do with the prostate. But based on, this is why every patient is individual. You can't compare patient A and B. Everyone is in their own little silo, and you need to address them from there and move outward.
Right. Great point. Keep the questions coming in the chat. Greatly appreciated. One of the questions that came up: how can we find a Black urologist? Is there a directory?
So not a directory, but you can always contact the National Medical Association. That is the largest organization of physicians of color. Also, blackdoctor.org. are probably two of the best organizations where you can identify Black urologists.
Great stuff. Great stuff.
And don't be afraid to ask your primary care provider for a black urologist in your area, because the odds are they know. They may not know them, but they know about them.
And depending on where you live geographically, there may be a little bit rarer. You may have to travel to a city to get to a Black urologist. So again, it starts with asking the questions to really kind of figure out what that looks like in your geographic location to see what you have access to. More questions coming up?
There was a question in the chat earlier about Agent Orange and veterans. So Agent Orange unfortunately causes an array of cancers. It causes bladder cancer, it causes bone cancer, it causes blood cancer, and it's associated with prostate cancer. So absolutely, that would, if you've been exposed to Agent Orange, that puts you at also significant risk.
Absolutely, absolutely. There was another question that came up earlier. Let's see. So one of the questions is looking through this, in looking through the prostate, one of the things we really try to help men do is advocate for themselves with Prostate Health Matters. The information that we're sharing tonight with the Delta Research Education Foundation are really for people to take in and absorb. We want you to go back and look and really try to comprehend what this information means, but most of all, how can it help you, again, ask more informed questions. So one, you're going to get the best treatment, you're going to get the best outcome, but you also ask what are the best options based on your cancer diagnosis. As Dr. Kennedy alluded to earlier, we talked about the Gleason score. The Gleason score is going to study the grade of cancer. So when they do those core biopsies of 12 or 16, they're looking at the grade of cancer, the velocity in which the cancer is actually multiplying within your body. And anything less than a 7 is good. However, the order in which they come also may be particular, because you can have a 3+3, which would be stage 1 prostate cancer. You can have a 3+4, which would be stage 2. But I actually had a 4+3, which is a more aggressive form of the cancer. So when I look at that, and I've had people where their PSAs, not PSAs, but their Gleason scores are actually 10. So if it's usually that high, chances are the cancer's metastasized, which means it's now in other parts of your body. And usually when it gets to that point, men are usually going to the doctor because they have symptoms, they have pain, they have ailments or aches or stuff, not just in their prostate, but probably other parts of their body. So we want to make sure as men are navigating this cancer journey, understanding what to look for in the cancer journey, it's all about setting up expectations and understand the risk associated with that. You're going to be your best advocate, but let's, again, be realistic with yourself. Realistic expectations as far as what it's going to take to get through this. And as I mentioned, with the martial arts mindset, mentally and physically and spiritually, you need to be conditioned. You need to be prepared for what to come, because you don't know exactly the path the cancer is going to take. But if you're prepared for it, you'll be able to withstand and endure whatever it may bring. And that's one of the key things we want men to walk away with and their families, because as we mentioned earlier, cancer is something you don't want to do alone. Cancer is something that does require a village, it does require a family, your spouse, your significant other, your partner, whoever the case may be. We want to make sure they're involved, especially when you go to the doctors. Men, don't go to the doctors by yourself, because as soon as that doctor mentions the word cancer, everything's going to be like Charlie Brown at the end of it. You're not going to hear anything after the word cancer. And this is important because we want to make sure that the people are with you, capturing all the information to put you in the best place. This is really important. I want to go back and talk about one of the other things. We mentioned earlier about there's 8 states right now in the country that are actually offering free prostate cancer screening. And this is a little alarming because these are the states that have been more proactive when it comes to talking about prostate health. And I mentioned this up because we were actually instrumental in working with DC. Back in 2023, Zero Cancer reached out to our organization and asked would we testify on the DC bill to offer free prostate cancer screening to men living in the DC area. We agreed. We were one of 3 people asked to testify for this. And in doing so, it was instrumental to figure out, one, they wanted to do the prostate cancer screening at 45. We said, no, it should be 40 because of the family history and the large African-American community that lived in the DC area. They agreed, but also we knew it was going to take time. So If you lower the age now, then you have to go back to the insurance companies, the doctors. Everybody has to be online to make this work from a community point of view. These states had to do the same thing. Last week, Zero Cancer reached out to us again. They said the state of New Jersey now has the highest incident rate of cancer cases in the country. We're trying to do a similar bill like we did in DC. Would you testify on this on behalf? And we said yes. And the reason why we said yes, when you look at this, there's 8 states that have done this. That means there's 42 more states to go, which means we've got work to do. So if we can get more states working with us, working with their residents to help them better understand and navigate them health, it's going to get everybody healthier. It's going to help keep the people out of the medical system. It's going to help lower cost of insurance premiums. This is a ripple effect of change, but it starts by the early diagnosis, early understanding. What can we do? What can we do differently to make that work? We have a question here. Can we get a Gleason score if we have cancer? So outside the PSA district. Yes. So yeah, Gleason score is if you have cancer. You're not going to get a Gleason score before cancer, because a Gleason score is actually measuring the density of cancer within the prostate. So if you don't have cancer and they're doing core samples, it's going to come back at a very low number, probably not a number at all. But again, we're looking at the grade of cancer within the prostate to understand what does that really mean. And when I say velocity and the density, it's really how fast is that cancer spreading and multiplying within your body. Is one of the things that I did mention earlier. When my cancer was detected, again, I mentioned I went from a 3.32 to a 4.32 1 year, but that 6.5 month trek, when they actually took it out, I went to a 7.68. So my cancer was starting to do a trajectory like a hockey stick, which means the velocity of the cancer was more aggressive, and it became more aggressive as time went on. So that's another reason why we want men to be more proactive when it comes to their health, because you don't know how fast that cancer may be spreading. And it's a good thing to get it checked. For those men that are doing active surveillance, even though they recommend to do it annually, for active surveillance, if you do have a 3+3, I'd recommend at least every 6 months, because you never know when that cancer is going to change and become more aggressive. You just don't know. And like I said, some of the things we talked about earlier are based on what you eat, things that you consume, things that also contribute to prostate cancer, alcohol, sugar, as mentioned by Dr. Collins, high levels of testosterone. If you're taking those T boosters and whatnot, it's like putting gasoline on a fire. And that's the last thing you want to do, because what happens is it's going to help accelerate the rate in which cancer is going to be spreading in your body. These are things that people, as the cancer didn't happen overnight, we don't expect people to flip a switch and it happened overnight either. So these are things you're gradually going to have to incorporate into your lifestyle, because it is a lifestyle change. And we realize it's going to be hard for some. It's just like the weight loss. Weight loss, people do the binging and whatnot, and it's one of those things. It's a yo-yo diet. But we want to be able to impart information and things you can take back that you can assimilate into your daily routines to help you understand and navigate this and see the gradual changes. These are things that hopefully will resonate with you sooner rather than later to get you to where you need to be. At this point, we're going to ask any more questions in the chat.
Mr. Butts, I'm going to add 2 things when we talk
Sure.
about lifestyle. We often very commonly talk about exercise and diet. 2 things I
Yes.
really want to highlight that are also very important. We've seen it in terms of how you respond to cancer treatment is the amount of sleep you get.
Yes.
Is very
Very important.
important. All
Yes.
adults should be getting
Great
7
point.
to 9 hours of sleep per night. And stress has a significant impact on cancer cell growth and development, but also response to therapy. So, in addition to when we talk about diet and exercise, I want to make sure people also remember you have to control your stress.
Absolutely.
I'm talking to Black people, it's hard, but yes, we have to do stress and sleep, also really, really important.
Absolutely. Another question here in the chat. The HIMSS Act, HIMS Act. Are any of you familiar with that?
I think that's the act that was put forth to ensure that health plans and insurers covered PSA screening.
Okay. Good point. Good point. Are there any reliable clinical studies that show how the change in diet affect prostate health? Any credence to having specific diet based on blood types?
I,
Interesting
I
question.
Yep, very. The latter part, not sure. I would have to do a literature search. Nothing comes to mind offhand, but there is tons of studies and data that looks at the diet and prostate health. Just as an example, as we're getting ready for the summer, there was a study that looked at the risk and progression of prostate disease for charcoal barbecue. So really,
Yes.
if you want you're really looking at how much, yeah, how well done you cook your meat, and being really careful because of the carcinogens that are released from the smoke that go into the meat. So yes, there are definitely some. As part of the All of Us campaign, we look at other studies that we can pull from that campaign. There's actually a nutrition study that is going on. I don't think it's closed yet. That really is looking at the impact of diet longitudinally over many diseases and cancers included in that.
Okay, great points, great points. As we're closing up here, I'm going to give each of you 1 minute to kind of give a closing statement or remark, please. We definitely thank you both for coming up on tonight. We greatly appreciate the insight. But any parting words of wisdom before we leave?
Again, thank you so much for the invitation. It's important that we continue to have the conversation. I encourage everybody to do four things: learn as much as you can about your family, educate those around you about the importance of screening and testing, participate when you can in clinical trials and research, and advocate. We don't do enough in terms of
Right.
advocating to our legislators on things that are important to you, things that are important to your family, things that are important to your health. We have to remember that our legislators work for us. And so we should really be talking to them regularly. Again, wonderful conversation. Thank you so much.
No, thank you. Dr. Kennedy.
Yes, I agree with everything Dr. Collins said and you said, and most importantly, you be the leader of your care. We have forever will take better care of our motor vehicle than we will of ourselves. And I think when you just take the time to do the simple things, and this is still about asking questions.
Yes.
Start with someone that you can relate to. And if you don't think they're listening to you, give it one more try and then find someone else. There are too many providers out here who are more than willing to do the right things by you, because your wellness should be our main concern. And thank you
Absolutely.
for having me, for sure.
No, great point. Dr. Collins and Dr. Kennedy, would greatly appreciate both of you coming on and talking tonight and sharing in this fireside chat. And also with special thanks to the Alpha Phi Alpha Mu Lambda chapter in the DC area for hosting this event to have this discussion. It's a very timely discussion as we're celebrating Men's Health Month. And we want to make sure men, as we really are focused on prostate cancer now, we want men to focus on all of their health. Prostate cancer just the one we'll focus on tonight. But when you know your numbers, we want you to know all your numbers, not just your PSA, but your diabetes, your cholesterols. All those numbers are important. For those in the chat, thank you again for joining us. We greatly appreciate it. And if this is of interest to you to see more of like this, please put in the chat. We'd like to see more discussions like this. We'd like to have more virtual fireside chats. Please let us know so we can put some things together for you and come back with more information of things that are more interest to you. So we want to make sure we address all the different services. And what we'd like to do is target those different months with the different health topics of the month. So, as Dr. Collins has talked about, breast cancer, some other things, colorectal cancer, all those things we want to make sure we try to address in some form of fashion. With that, I'd like to thank everybody for coming and participating in our event. We greatly appreciate your support. And again, we want to help every man get a grip on prostate cancer. Be proactive, be healthy, have a good June, everybody. Take care. And thanks again for joining us.